Good evening, everyone. We are going to start the 25th edition of the Glaucoma Journal Club. And first of all, I think we should congratulate each one of us for reaching this phenomenal milestone. The journey started way back in 2015, and I have been informed that this is probably the longest running ophthalmology journal club in India. So I think it's a great thing for all of us. We are grateful to the Office of OSWB for being associated with this special edition of Glaucoma Journal Club. There was a time when we had only 15-20 attendees, but CIPLA continued their academic support. And the most commendable thing which I'll say is that in last 9 to 10 years, they have never pushed any article or any presentation which have supported their products. So it has been a very purely an academic forum. And the best thing about this journal club is that it has given opportunity to a lot of young budding glaucoma specialists who are now one of the leading practitioners and most sought after speakers in the city. There are a few reasons why I think we have been successful over last decade. One important thing is that the guidance of seniors like Sumit sir, Suchanda di, Maitri madam, Dr. Thakur, Souvik Banerjee sir, Neela sir, their guidance and their mentorship has helped us. Also, very important thing is that unmatched thirst of knowledge which we all have. We all want to upgrade ourselves. We all want to learn new things, practice evidence-based medicine. And most importantly, I think the glaucoma consultants of Calcutta have a beautiful cohesiveness and camaraderie which helps keeping this journal club running for almost a decade. I'm also very grateful to MB sir, Dr. Bhaskaran sir. Sir is been my teacher. And on this special occasion, we are having a national faculty, and he has got a very interesting presentation that how in the last 9 to 10 years, the glaucoma management has evolved and what new things we have learned. So I'll request first Secretary OSWB, Dr. Debashish Das sir, to say a few words. Then I think Arjit has prepared a very interesting presentation, and then we'll start the talks. Sir.
Good evening. This is basically this journal club, whatever it started, as Manish has said, gave me the idea that if it can be a journal club of glaucoma, why not the other faculties be left behind? With that, in the year 2020-22, we started the journal club for other streams also on behalf of OSWB, and that is also sponsored by CIPLA. I congratulate CIPLA for continuing the journey, not only with the glaucoma, but for the other faculties also. OSWB has conducted 4 such journal clubs earlier over the last 1 year. And let me tell you, with the OSWB journal club coming into prominence, there are other states which are following the OSWB schedules and are now having their own journal clubs in their own states. I'd like to invite Dr. Mani Bhaskaran. We had worked together at Shankar Nethralaya in our younger days. I've loved to see him again today evening. With that, I'd like to pass on the baton to Dr. Orijit Mitro and Dr. Mani Singh to conduct the session today. Thank you.
So, good evening, everybody. So, it's the 25th Journal Club, and it just seems like yesterday that I was one of the speakers at the first journal club, which was held in Calcutta in 2015. So we landed in Kolkata in 2014 from Arvind, and 2015, Manish Da just gave me a call, and I just remember I was there. So it's been a long journey. It's been a wonderful journey, and all of us have contributed. Each and everybody, seniors and juniors alike, they've contributed. So I'll just like to go down memory lane, and because of COVID, there was a little bit of a gap, and I don't know, I formatted my phone and I don't have the previous journal club flyers, but these are some of the journal club flyers that I do have. I mean, I asked Manish and I asked a lot of other people, and they could not provide me with the flyers for the previous journal clubs, but this was one of the older ones, the 17th journal club in 2020. So even post-COVID, which started back with the journal club, this was the 18th, this was the 19th, and so on. So it just carried on. We just had newer speakers each and every time. And things have evolved, and now we've kind of developed a particular format, and it's really been a very enjoyable journey. So this is a picture from the first Cipla Journal Club, Jan 24th, 2015, at Hotel Golden Park. And I still remember there were hardly around 15 people there. Manishda was moderating the program. I was one of the speakers. And at that journal club, I presented this particular topic. So we've chosen some really nice topics. Some of them have worked over the years, some of them haven't. So I just want to go back to this particular topic which I presented, which I thought at that point in time was something groundbreaking. So this was a topic on taking retinal neuroprotection from the lab to the clinic. So it was called the glucose story, where basically what was done was, they took a group of POAG, non-diabetic pseudophakic patients, and they gave 50% glucose to one group and saline drops to the other group every 5 minutes for 60 minutes. And the result was, or they inferred or they concluded, that topical glucose temporarily improves psychophysical visual parameters in some individuals with POAG, suggesting that neuronal energy substrate delivery to the vitreous reservoir may recover function of sick retinal neurons. So this was about applying glucose drops to your eyes. However, this has not come to fruition, so this has not really worked. So I presented this at the first journal club, and then there were a lot of numerous speakers, numerous new presentations. We went in search of newer venues, and we had amazing panelists and amazing discussions. With Manishda was always very particular to take photographs and to keep looking at the photographs. And me, as usual, I used to bore people with discussions. So in the 15th Journal Club, I presented this article, and I still remember Shurojit and me having a discussion after this. So this was a very unique delivery system. So it was basically attached to a non-valve device. So this is the device. This is a bar welt or an RD. So when you attach this device, it regulates the flow of aqueous. So basically this particular device, which we presented at that time and we laughed it off, it has come to fruition. At this year's WGC, it is being marketed as iWatch. So there's this new company which has kind of taken over the previous one, and you have a compass here and a magnet here. So once the device is implanted in the eye, what you do is you move the magnet to either open or close the flow of aqueous. So there are certain topics which we have discussed and they've added value. And there are certain topics which really didn't make any sense. So now, this is another device which is being developed based on that. So this is an article from 2023 where you have this magnetic pin which regulates the flow of aqueous. So these are some of the topics that we've been discussing and pushing over the years. So newer speakers have presented numerous amazing topics, and we've had amazing discussions. So Gitanjali, Joyashree, a lot of new speakers have come in, and the older ones, Shurojit, Tomonash, Pallavi, all of them have been there. Nazneen was missing in action for some time. Again, she's back. So a lot of activity and buzz has been there around. So we've had a really fun journey. I don't know why, but we are looking really young in this picture. And this was not too long ago. I think this was just a couple of years ago. I don't know, everybody is looking young. Maybe it's because of Manishda's front cam or something, I don't know. But everybody is looking really young in this photograph. So now we come to this journal club, and we're looking forward to 3 amazing articles and Manisha's talk, of course. So the first topic is going to be discussed by Debashish Da, Dr. Debashish Chakraborty. Debashish Da did his MBBS from Medical College, Kolkata, and his MS from MKCG Medical College, Behrampur, Orissa. He did his long-term glaucoma fellowship at LVPI. He has been awarded the FICO in phaco as well as the FICO in glaucoma. He has several publications and book chapters to his credit, and currently he is the senior consultant in cataract and glaucoma services at Center for Sight, Kolkata. Now, why we chose this particular topic on trabecular procedures combined with cataract surgery for open-angle glaucoma is that MIGS has now taken over the world in a big way. So if you look at the US MIGS market, it's around $150 million at the moment, and it's increasing with a CAGR of 5.3. So it's an ever-expanding market with all the devices having their fair share. And not only in the US, the UK market, the European market also is expanding. And over time, by 2030, it's going to be huge. And it's going to occupy all these countries. I mean, all the countries involved, Germany, UK, France, Belgium, and the rest of Europe. So this is going to be something very, very interesting to see where it really heads. Because the market is ever expanding. Already the US market is really the biggest market at the moment. But if you look closely, the Indian market is the fastest growing market at the moment. The Southeast Asia, India, and Australia. So we really have to discuss about these topics because this is what is going to be probably the future. Now, if I look at PubMed, and I want to see where academics are really matching the finances. So if you look at the AGV, you just put in a glaucoma search in PubMed, and you see that over the years, around 954 results are there on PubMed. Now, if you look at Okta, there is this sudden boom, and there are 11,000 results. So there's a lot of buzz and interest in Okta. And if you look at MIGS, there are around 757 results already, and you can see a huge spike. So you see the number of papers which are being published yearly has crossed 100. So in fact, it's touching 153 in 2022. So there is a lot of academic buzz, and there is a lot of surgical buzz around MIGS. And therefore, this particular topic is really important to discuss. So I call upon Debashish to talk about trabecular procedures combined with cataract surgery for open-angle glaucoma.
Thank you, Arijit, for the kind introduction. And thanks to CIPLA for supporting this novel initiative, echoing Dr. Debashish Das. I think at least regarding this initiative, what Bengal thinks today, India thinks tomorrow. And we have a special guest today, Dr. Mani Bhaskaran from Shankanetralaya. Welcome, sir. So I'd go directly to the topic. So this, the heading of this topic is trabecular procedures combined with cataract surgery for open-angle glaucoma. So this is an ophthalmic technology assessment, and the report is published by the American Academy of Ophthalmology. So I'll directly go into the topic. So there were three study questions. The first one was to determine the extent of IOP reduction of the various trabecular mixed procedures combined with cataract surgery compared with cataract surgery alone. Second is to compare the safety of the various trabecular procedures. And third is to highlight if there are any particular patient characteristics that may favor one mixed procedure over the other. Now, a little bit of background is essential before we dive in. So, what basically is MIGS? The conventional definition is that these are ab interno micro-incisional approach, but over a period of time, this has been extended, and we have some ab external procedures, for example, the Zen or the pressure flow and other such procedures. But what is common is that they involve minimal trauma or disruption to the normal anatomy and physiology. They have demonstrable and reliable IOP lowering, extremely high safety profile, and rapid post-operative recovery with minimal need for follow-up. Now, there are various mixed procedures depending on the anatomical site they target. So, we have the Schlemm's canal procedures, the suprachoroidal space procedures, the subconjunctival space procedures, and the ciliary body procedures. Now, this study focuses on the trabecular meshwork procedures. So again, the trabecular meshwork procedures can be achieved via trabecular bypass, like the eye stent, the various generations of the eye stent, by Schlemm's canal dilatation, like the Hydrus, which of course involves a trabecular bypass also, or either there are procedures which can disrupt the trabecular meshwork in the Schlemm's canal, like the GAT, or incise some part of the trabecular meshwork, like the KDB or the trabectome. Now, although this, the heading involves trabecular procedures, but this study actually involved three procedures. One is the eye stent, another is the Hydrus, and another is the KDB. So, a little bit of information of this. The eye stent inject is the most commonly performed MIGS surgery worldwide, and it has been invoked since many years. The basically device consists, it's the smallest implant that is done in the human body, only 0.3 millimeter in length. It's a heparin coated non-ferromagnetic titanium stent, which consists of three parts: the head, the thorax, and the flange. So the head, it resides in the Schlemm's canal. The thorax is held by the trabecular meshwork, and the flange secures the placement in the anterior chamber, and it shunts aqueous from the anterior chamber to the Schlemm's canal. And the stents are lodged in this injector, and with the push of the button, the two eye stents are injected in the trabecular meshwork. Next, we have the hydrus. This is a longer device. It's about 8 millimeter long compared to only 0.3 millimeter of the eye stent, and it occupies about 90 degree of the trabecular meshwork. It has 3 windows and an inlet. So the windows pass into the Schlemm's canal, and the inlet lies in the anterior chamber. And whereas the eye stent is made of titanium, it is composed of nitinol, which is an alloy of titanium and nickel. And the third is a Cahook dual blade. So the Cahook dual blade has a sharp tip and 2 parallel blades which are sharp. This actually involves a novel goniotomy where we excise some part of the trabecular meshwork. So as the device is moved circumferentially along the canal, the dual blades excise a parallel strip of the trabecular meshwork, thereby exposing the outer wall of the Schlemm's canal. And this probably enables more complete removal of the trabecular meshwork as opposed to the bang. Now coming to the study methodology, this is basically a systematic review. So the PubMed search was conducted initially in February 21, and then it was updated in April 23. And total 279 articles were selected, out of which the final selection was only 10 level 1 randomized control trials with robust methodology. So these eliminated any studies on the trabectome, ab internal canaloplasty, and GAT procedures. So basically we are dealing with eye stent, hydrus, and KDB. So regarding the published results, all the studies were industry sponsored, and because most were authored by consultants and stockholders in the study technology, there is a risk of industry sponsored bias. The participants were patients with hypertensive mild to moderate open-angle glaucoma on medications and undergoing cataract surgery. This is important to remember because the results of one study cannot be extrapolated to some other population. Although some studies included only primary open-angle glaucoma, there were some cases of secondary glaucomas also, like pseudoexfoliation glaucoma and pigmentary glaucoma. Now, regarding the IOP control, which is the basic crux of the study, so there were studies which included medication washout, and there the focus is on the mean IOP reduction. However, in studies which did not mention a washout, it was necessary to report mean IOP reduction along with the mean medication reduction. So these are all the studies that were included. This is the clinical trial data without medication washout. These are the clinical trials with preoperative and postoperative medication washout. These are the study outcomes based on success definitions used by each study, and so on. Now, it would be extremely, it would take up a lot of time if we discuss each of these procedures. I would just touch them briefly. Like for the eye stent, you know that there are 3 generations of eye stent. The current generation is the eye stent Inject W with a wide flange. So it has the longest duration of study. From 2011 we have. So the first study was with the eye stent, the single eye stent. And there we see that it was, so they compared cataract surgery, the phaco with eye stent versus cataract surgery alone. So it was 8% versus 5.5%. And if you come to the medication reduction, this is 87% versus 73%. So similarly, we have other studies, and on this eye stent, we have studies on the hydrus, we have studies on the KDB. I would go to the summary for the sake of time. So if you come to the summary, all 3 procedures reported similar percent IOP reductions in their cataract surgery alone groups, 28%, 28%, 21%. That is, even with a normal cataract surgery, the IOP reduction in open-angle glaucoma, these studies show that it's on an average about 21 to 28%. And the mean IOP reduction, which in terms of millimeter of mercury, this is about 5.4 to 7.6 millimeter. If we add another MIGS procedure in addition to the phaco, then what is the additional IOP reduction? In case of eye stent, it is 3.8%. In case of the hydrus, it is 8.7%, and 8.9% in the 2 studies. To summarize, although the currently available versions of the procedures described above have not been compared directly with one another when combined with cataract surgery, The three most studied trabecular procedures appear to produce similar results among hypertensive mild to moderate open-angle glaucoma patients with modest IOP reduction or medication reduction over cataract surgery alone at 2 years, and there is no clear benefit of adding one trabecular procedure to cataract surgery over another based on this available data. So whatever the companies may claim, all these studies, if we pull them together, there is no definite evidence that one may be better than the other. So regarding the, according to the available medication washout studies with the 2-year data, an additional 4 to 9% IOP reduction can be expected by adding a trabecular procedure to cataract surgery over cataract surgery alone, which itself reduces IOP by about 21% to 28%. So I think this one line we can remember from the entire presentation is that if we do cataract surgery alone in primary open angle glaucoma patient, we can expect an IOP reduction of about 21% to 28%, whereas if we add a trabecular meshwork procedure, mixed procedure, it will involve another extra IOP reduction of 4% to 9%. Now coming to the other aspects of this study, the adverse effects. So eye stent on an average, it reported an adverse effect of about 2%, foreign body sensation, stent obstruction, some cases of hyphema, but no cases of hyphema occurring more than 10% of the anterior chamber, and uveitis. For hydrus, the adverse effects reported were uveitis or iritis, corneal edema, some intraoperative adverse events like hyphema, cyclodialysis cleft, device malposition, iridodialysis, corneal abrasions, DM detachment. And the device was not successfully placed in 2.9% of eyes, either because of anatomic restriction in Schlemm's canal or hyphema obscuring the surgeon's view, and peripheral anterior synecdoche. So basically again IOP reduction. So regarding the endothelial cell loss, so this was a secondary IOP lowering surgical interventions. So if you consider the eye stent, 1.6% in the eye stent inject group versus 3.4% in the control group required secondary IOP lowering surgical intervention at 3 years. That is, with the hydrus, it was 1.1% versus 2.7%. And another study showed 4.9% versus 7.5%. So if we do a mixed procedure along with a phaco, then at least for some years we can delay another glaucoma surgery. Regarding the endothelial cell loss, which is a concern, as we know that some devices like the CyPass was withdrawn because of endothelial cell loss. So some endothelial cell loss can occur with eye stent and hydrus, but it was not statistically significant, and it is less in KDB than in eye stent. Regarding the surgeon considerations, which is very important, particularly for surgeons who are beginning to do the mixed surgeries, the learning curve for trabecular procedures with respect to patient positioning, microscope manipulations, intraoperative gonioscopy, and surgical technique differences. So as we all know, we have to gain mastery with intraoperative gonioscopy, because the most crucial thing for all these procedures is good visualization. Unless we get a good visualization, we cannot implant the device or do the procedure in the proper place, and all the problems come up thereafter. So the studies available on the iStent Inject and KDB did not report on this learning curve, but the Horizon trial did report that 2.9% of those in the hydrus group did not receive the implant, and an additional 1.6% had a non-optimally placed stent. Thus, there may be anatomic limitations like narrow Schlemm's canal or other unknown technical limitations, causing approximately 5% of eyes to not achieve a properly implanted hydrus. Now, regarding the patient selection, it's very important to understand the participants in these studies described in this assessment were patients with mild to moderate hypertensive open-angle glaucoma undergoing cataract surgery, and they were required to have a baseline untreated IOP of 22 millimeter mercury or more. So we cannot extrapolate the results to other glaucoma subpopulations. For example, it will not work well for advanced glaucoma patients, patients who have very high IOPs, patients who have normal tension glaucoma. We cannot extrapolate the reports of this study. So the investigators generally excluded patients with a history of uveitis or metal allergy. The inflammation, intraocular inflammation was more common with hydrus and eye stent, where you are leaving a foreign body rather than the KDB. And patients with a prior history of uveitis or risk factors of uveitis therefore are not ideal candidates for hydrus and eye stent. Regarding the metal allergy, patients who have an allergy to nickel should not receive the hydrus implant because it contains nickel. Titanium causes less of allergy, but again titanium allergy testing is very difficult. Regarding uveitic glaucoma, KDB may be better somewhat compared to the eye stent or the hydrus, because it can reduce the trabecular resistance, by excising a part of the trabecular meshwork, but on the contrary, it can also open up the blood aqueous barrier and can promote inflammation. So regarding the other considerations, bleeding is a consideration. It's more with hydrus and KDB rather than iStent. iStent is a very small device and it covers only 1% of the entire trabecular meshwork, but hydrus is a longer device and KDB involves excision. Narrowing of the Schlemm's canal, KDB is probably better than hydrus or iStent. And regarding normal tension glaucoma, there is no data because the study population was different. Now, very importantly, what is the potential industry sponsorship bias? As I have already mentioned, so it's important to highlight that all clinical trials on trabecular outflow procedures discussed in this assessment were industry sponsored and thus subject to potential industry sponsorship bias. Nearly all the first or corresponding authors with financial interests in specific companies, and therefore we need future trabecular procedure studies by non-industry sponsors. So to conclude, the trabecular procedures offer mild additional IOP lowering over cataract surgery alone in patients with hypertensive mild to moderate open-angle glaucoma. And although the primary goal for MIG surgeons is often to reduce the medication burden, the mild mean IOP reduction of approximately 2 mm mercury by a trabecular procedure is estimated to result in a mean reduction in number of medications of 0.4 at 2 years. So to conclude, which trabecular procedure to choose out of these devices would depend on the surgeon experience. One may be comfortable with one device rather than the other, and patient-specific factors like the history of uveitis, presence of secondary glaucoma, metal allergy, bleeding risk. So these are the conclusions from the study. If we discuss what my personal conclusion is, so these, the MIGS procedures, as we all know, they are creating a wave worldwide and in India, and several centers are doing, some of us have done some of the procedures, and we know that we have to learn this procedure if we have to remain afloat as glaucoma surgeons, and the more we try to do these procedures, the better it is. So regarding this study, out of the 3 devices that they have mentioned, hydrus is not available in India, iStent and KDB are. There is some price difference, but overall they are costly devices for many of our patients. We have other procedures, other trabecular procedures like the BANG and the GAT, which they have not discussed. But I think as glaucoma surgeons who are learning these new procedures, we should take interest in these procedures, and we should try to find patients who can afford these procedures, and I think over a period of time we will know the nuances of this procedure, why these procedures can work in some patients, why not in others. And I think over a period of time we will have studies that we can produce from India, and we can know how these devices actually work for our patients. Thank you.
Thank you, Devashishda. It was a vast article and he has very nicely summarized it. And this is a very burning topic we all want to discuss about MIGS. And for discussing this, we have expert panel of Dr. Nilay Majumdar. Sir, why don't you come in front? And Dr. Alokesh Ganguly, Dr. Dipanjan Pal and Dr. Prashant Srivastav. Before we go to the expert panel, I also like Dr. Bhaskaran sir's opinion, because I know sir has been doing KDB for almost more than a year, I think. Sir, what is, just very simply, your indications and which is your preferred and why? Preferred technique for you and why?
See, from the journal point of view, couple of points I want to make. One is that, the gonioscopy data is not available for all the RCTs. And we know that the number of patients who undergo gonioscopy in the Western setting is not that much. So we don't know how many of them are actually having narrow angles, and the cataract surgery contributed to much higher lowering in intraocular pressure in them. So that we have to take it with a pinch of salt. And of course, the amount of IOP reduction vis-a-vis the cost of the, these procedures is something we have to keep in mind for our context. Most of our patients are. So ultimately, some of these devices are for the elite patients who are coming to us. So that is something which you have to keep in mind. So keeping that in mind, and as well as the 360-degree trabeculectomy that is done in the GART procedure, which is a bit dicey, we have decided to do most often KDB goniotomies, or one of the other procedures which you was talking about. KDB, we do it because the leaflets don't fuse together, and that is a device which is already there. So that's what we are sticking to. iStents we are doing in small numbers because of the cost factor. Apart from that, yes, we need to look at what holds good for in the future with all these devices, and we have to see how it goes.
And any particular indication, sir, where you think?
We are only doing it in mild glaucomas. Ocular hypertensives, we are not doing it because we know that regression to mean is a problem with ocular hypertensives. And with the ocular hypertension treatment study, which I'm going to highlight a little bit about, 20 years follow-up, there are patients, only 40% of them, they progress, but not to blindness. So there is probably not a need for doing a procedure in such cases. So mild glaucomas is where we are doing it. Very small number of group of patients we are doing it.
Alokesh, your comments, because I think one very important point highlighted in this presentation is that a lot of studies which we are reading in articles or even the company people are coming and sharing, a lot of them are actually sponsored by companies or are done by people who are some way associated. So how are we going to understand which is a useful modality for our patients?
That's a very difficult call to take, I think, at the present moment. Basically, as this study shows, the amount of decrease of IOP is perhaps not very relevant to the type of the patients that we normally see in our OPD at presentation. That is one part of it. And the other part of it is, I just wanted to just share with you that, it's a very vast paper. And, at one part of it, Devashish, it says that as they extrapolated from the Horizon trial, that these patients in the trabecular procedures showed a decrease in the visual field changes over a period of 5 years. That is also highlighted in the study. Now, that Horizon trial I had presented somewhere, so it didn't seem to match, the amount of IOP reduction by these and the changes. What had happened is actually, because they had done the cataract surgery, they had excluded all the previous fields because of potential error of performance with the cataract. And so, as we all know, in these large subgroups, there are slow progressors and fast progressors. That was not taken into account. So in the Horizon study, the conclusions that they drew, that over a 5 years period, the progression was lesser with this trabecular procedures also has to be taken with a pinch of salt, because the individual IOP reduction only on the trabecular procedures does not match with it.
So just carrying on from where Alokesh left off, so if you look at this editorial from Dr. Tanuj Dada, what he has stressed on is eventually what you're getting at is a reduction of 0.4 drugs at the end of 2 years. This is number one. If you look at another study by Jennifer et al., this is one of the latest studies, 2024, it's from Australia, they kind of corroborated it. With eye stents, the number of reduction of drops is 0.6 at 2 years. But what is interesting is what they've written, that there is no significant difference in IOP between the cataract group and the eye stent group. So that is alarming. So you may have a little bit of reduction in the number of meds, but you're having no significant reduction or difference in IOP. Also, when we look at the other stripping procedures, so now there's this stripping versus stenting debate. So Dr. Dada in another article had discussed that it should be restricted, only limited to the nasal quadrant. So probably KDB and BANG are better. Now, is GAT at all an alternative? Because there are these distal outflow pathway resistance issues which we do not know, and there are these non-linear relationship between the extent of incision and the IOP. Also, this particular study, which was done by Aiki Ahmed, and it was published way back, it showed that Hydrus is better than MIGS, which is similar to this particular study. Again, the difference in meds between Hydrus and iStent group was again 0.6. So even, iStent is worse when it comes to, comparison between either Hydrus or even cataract. And look at this interesting fact. It stated that standalone iStent without cataract surgery does not give good results. So this was published in that particular study way back in 2019. So, a lot of questions are there. So, should we opt for these stripping procedures at all? Is there a cost-benefit ratio justified for stenting? Which MIGS would you opt in the present scenario? Is an angiography-guided eye stent better? If you do an angiography eye stent, where would you put the eye stent? Would you put it in the region where the collector channels are seemingly patent? Or would you put it in the opposite end, where the collector channels are not patent? So there are a lot of unanswered questions. And basically, because the reduction of meds is really poor, so is it worth it? And can they be done in angle closure patients like Manish sir mentioned? So I would just like to ask the panel whether it is at all at this point in time a viable option to do it. I mean, in terms of, let's say, eye stent. Dipanjana, please. Dipanjana has done a lot of KDBs, I know. KDB
I
seemingly
cannot
giving good
say
results.
much about eye stent, no experience, because it is difficult for us to make a people ready for eye stent. As he's spending lot of money, sometimes we need to actually substantiate why we are giving an eye stent with 1.6 lakhs. So it is difficult. But if I see that for the mild glaucoma patient that Dr. Moni was telling, I am actually around a year with KDBs, and my first done patients were started doing around January 2023. That we are seeing around a year. At least we are seeing them off prostaglandin for 1 year. With stable visual field. Of course, their visual field defect were mild group, but there had been no progression in the field. And intraocular pressure, excepting one patient where I was a bit over-enthusiastic. The patient around 6 months, he presented with single-digit intraocular pressure. And so I was tempted to stop medication, and there immediately the pressure shot up. So we had actually started medicine, and now he is better. Accepting that, I am only at 1 year result. So I have done around 36 cases, 36 eyes. So mostly for my side, that at least they are not using prostaglandin and eyes are not red. The patient is happy. The most good part is the patient is having one glaucoma procedure and he is not, the reduction of medication is the primary thing that I tell the patient, and it happens. At least in KDB it happens. And the patient sees pretty well, and that is usually not the case when we do a combined trabeculectomy with thing. So these are the advantages. But eye stent, I am not sure. I am going to put probably the first eye stent end of this month, and then we can discuss.
Thank you, Dipanjana. Niloda, your experience, what would you kind of advise people who are on the brink of taking the plunge?
Why people?
People who are on the brink of taking the plunge, whether to do MIGS or not to do MIGS and which one to do.
Actually, this paper came at the moment when I personally was all set for starting MIGS with learning all these procedures like buying a surgical gonioscope and tilting the patient's head, microscope, etc., and seeing the trabecular mesh for the first time was a great excitement for me. But then this paper particularly is a bit of disappointment, because we hear a lot of milds in this paper, or for that matter, the paper by Dr. Tunuzada also. So we use it in mild glaucoma. There is mild reduction of intraocular pressure. Obviously, the side effects are also mild. The problem is when the eye stent people came to us first, I don't know experience of others, they told it reduces the IOP by 30% combined with cataract surgery. Then I didn't know এই অ্যামাউন্টের মধ্যে cataract surgery is the most potent IOP lowering component, and this eye stent reduces only by 1.6%. So at the present moment, I think the procedures, the newer procedures are always welcome. We should all be ready for that. With the basic procedures like being able to see the trabecular meshwork with the prism, direct gonioscope, but at the same time, we should be careful about which patient to choose. At least for the profile of patient I cater, I cannot think of maybe more than 1 to 2 patients a year.
Right.
And the cost of this eye stent,
So,
it is probably,
yeah.
if the patient is using a prostaglandin, which costs 600 rupees, 20 years of this prostaglandin is one eye stent.
So, Manisha, one last word to all of us. At this present scenario, which MIGS would you advise if at all somebody is going in for MIGS procedure? And that's it.
I think in terms of procedure-wise as well as the cost-wise, easy on the patient as well as the surgeon would be KDB, goniotomy, or I wouldn't say KDB, but then the stripping procedures, the 2 limited stripping procedures. And because, the leaflets come together, and that is where we need to use something which is much more standardized. There are so many of them. KDB is there, then micro hook, all those Tanito hook, all those things are there. But again, what we do in our thing is each one of those probes, we use it for 3 patients. And that way, we are able to reduce the cost to the patient as well. So that is what we are currently doing. And obviously, we need to see whether other things can come in for. But as he said, at 1 year point, it is looking good. Beyond that, the pressure goes up. So it is a short-term efficacy procedure to postpone the trabeculectomy. So you need to have a very niche area of patients that you have to select. Selection of patients is very, very important, and learn the gonioscopy very well. At least 50 patients, when you are doing cataract surgery, do the gonioscopy and touch the trabecular meshwork with a hook or something, and then try to move on from that.
Thank you, sir. Thank you.
Please. Just a one-liner, maybe on a lighter note. The most of the glaucoma patients that we are operating is like playing a test match on a turning pitch in the final day, and you are on a follow-on. So it's not IPL. So nobody pays a reverse scoop in a situation like that.
We're running very late. I mean, I was very sure. I told Manish not to put this topic in the first day because we'd be running out of time.
Only one point.
Okay, one.
Down the lane, you didn't explain to the audience why the importance of MIGS is there in India. You have to explain.
Whether
that's the catch point. This is my personal communication with Dr. Andre Mahmood. The situation is US or UK is not the same on the Switzerland. They are bound to do it. What Andre Mahmood had told me, that the authorities who sanction the procedure, they mean that there is a block. Block means you have to put some stent. That's it. So they have cited the reasons for the cardiac block. You put a stent. So you are mentioning that there is a trabecular block. Why you are not putting a stent? Number 1. Number 2, the authorities thought, or the authorities believe, trabeculectomy is more disruptive surgery than MIGS. Number 2. Number 3, the cost or the timing for the procedure, they take less in MIGS than TRAB. And Sumita was there with me. Tariq Sharare also shared the view. But when I have seen IK Ahmed, the first presentation on MIGS at Boston WGC, and there are no takers. And if you think of the senior glaucoma consultant, Dr. Brian Francis, who developed the CyPass. So this is the thing, we have to remind it, the history will not forgive you. CyPass was launched in 2016 with a huge halla gulla, and in 2018 it was withdrawn because of several lawsuits and different things. Okay? So, and Joseph Caprielli, one of our followers, whom we should follow, very mild optic nerve damage. End of the day, that should be the message to the audience. Little nerve fiber layer damage,
correct.
Mild or moderate glaucoma, early visual field defect. Beyond that, TRAB is still the answer. Second point, if you don't know how to do a gonioscopy, you ask yourself, because
Should you?
Samuelson, you have heard?
Yeah.
Professor Samuelson.
Sam.
So he is of the view that because he is doing the eye stent since 2012, that it's a sensation. What a beautiful word. Seeing trabecular meshwork is a sensation. If you don't get that sensation in the OT, don't do an MIGS. And you should be very versatile with gonioscopy. Else you don't do it.
Okay. Thank you. Thank you for these valuable inputs. We'll quickly move on to the next speaker. An equally interesting, if not more interesting topic. And this is going to be discussed by Dr. Vidya. We all know her. She's been a constant here. So she completed her MBBS from Seth GS Medical College and KEM Hospital in Parel, Mumbai, and a DNB from the Mysore Race Club Eye Hospital in Mysore. She has done her cataract and community ophthalmology fellowship at SN Chennai. She has done a fellowship. She has earned a fellowship gold medal for a fellowship at Shankarnithalaya, Chennai from 2016 to 18. She is a member of the AIOC and the GSI, and she has 3 publications in international journals, 5 paper presentations, 5 poster presentations at state and national conferences, which I'm sure has increased. I think this is some old kind of a slide. So she's going to discuss on intraocular pressure while reading the smartphone digital text versus printed text in healthy individuals and those with glaucoma. So this is a topic which is going to interest each and every one of us. So I think we'll be all ears for this particular topic.
Good evening, everyone. Welcome, MP sir, to Kolkata. So today the topic we are discussing is intraocular pressure changes while reading smartphone digital text versus printed text in healthy individuals and those with glaucoma. This was published in the last month in Journal of Glaucoma. The purpose of the study was to compare the effect of reading for 30 minutes using smartphone and printed text. The purpose was not to study the effect on normal eyes versus glaucoma eyes. It was just to study digital versus non-digital text. So it was conducted in the Department of Ophthalmology in a tertiary eye care over a period of 6 months after the clearance of their Institute Medical Ethical Committee. The sample size they have calculated with an online calculator, and it was calculated separately for healthy volunteers and for patients with medically controlled open angle glaucoma, considering a power of 90% and confidence interval of 95%. Now healthy participants, we noticed that the age group is much younger, 18 to 40 years of age. They have excluded high myopes, high hypermetropes. More or less they have only included E-metropes with refractive error less than 1 diopter. And they have excluded shallow anterior chambers and high IOPs. For medically controlled open angle glaucoma, they have included patients who are well controlled with the same medications for the past 6 months and who have not undergone any laser procedure or any glaucoma surgery in the past. They have assessed the basic workup, clinical and glaucoma both in both healthy and glaucoma patients. Now for reading task, they gave a choice between Hindi and English literature. These are the literatures which they have given, and the participants were instructed to hold the phone and printed text material in their natural position, sitting on a comfortable chair for reading. This is the way the authors have decided to standardize the study so that the study can be replicated if wished. So they have both for text reading and digital reading, the font has been selected to Times New Roman font, having a white background, black print and a standard illumination of 400 lux, and they have kept it the same throughout the study with the lux meter. Now the eyes included, for healthy participants they included the right eye, and for the POAG patients they included the worse eye. The procedure went on like this. For healthy volunteers, a baseline IOP was taken for the study eye. Then the volunteers were reading the printed text for 30 minutes. IOP was assessed at 10, 20 and 30 minutes in these patients. After reading, pressures were again measured at 10 minutes and 20 minutes post completion of text material, and at the 20-minute reading post text material, they started the smartphone study where the participant read a text on smartphone for 30 minutes. Now again after the smartphone reading, they measured pressure for 10 minutes and 20 minutes post the smartphone reading. This is their sitting condition and the lux meter besides the participant, which is measuring the illumination of the room. The IOP was measured with eye care. Now participation was with 60 healthy volunteers and 22 POAG well-controlled patients. Mean age of the healthy volunteers was 31.2 and POAG patients was 49.4. Mean baseline IOP was comparable in both healthy and POAG patients. Now this is the IOP variation in healthy volunteers. If I may point out, the healthy volunteers, when they read printed text, they have shown an IOP spike. Also, when they read digital text on the smartphone, they have shown an IOP spike. The IOP spike with digital text has been more than the printed text, and more so at the 20-minute and 30-minute interval, which was statistically significant. So if we note here, the baseline, it has started from somewhere between 14 and 15. For smartphone reading, the spike has gone much higher, which was statistically significant as compared to the text reading. Now similarly, in patients with POAG, the patient showed a spike in the pressure with both printed and digital text, but point 2 we noted is with the digital text at a 20 minutes duration, the spike was almost 3.5 millimeters of mercury. Now here one thing, if we note, the baseline for digital, for non-digital text, printed text was somewhere around 15, and after the study for digital text was done, the IOP had not returned to baseline in patients with POAG, but still at the same point, the study was started for smartphone reading. So they found a significant rise in IOP from baseline as shown, and this we discussed. So they concluded that reading is associated with the rise in IOP in both healthy volunteers and POAG patients, and IOP rise is more marked with smartphone compared to printed text reading. Now, if we look back into literature, there are similar studies which have studied effect of reading from text or from mobile on the intraocular pressure in both glaucoma, non-glaucoma patients. This study, published back in 1995, has shown that the fall in mean IOP in group readers was significantly greater than in non-readers. Now, this and many more studies which have studied the effect have shown a drop in IOP post text reading rather than the current study which shows a spike in IOP. The studies which have shown drop in IOP have said that the ciliary muscle contraction which occurs because of accommodation during reading puts a tension on the scleral spur, opening the trap meshwork and the Schlemm's canal, thereby increasing the outflow. The similar study which has studied effect of reading on emmetropes has found accommodation reduces IOP. Now there are differences in other studies and the present study, and the authors attribute this to the wide age range and the refractive status of the study participants and the different reading conditions in different studies. Mechanism of raised IOP with smartphone has been attributed to sustained extraocular muscle contraction and accommodative convergence, which is much more with a smartphone than with a book, because people tend to hold their phones much closer to their eyes than the book. Merits of the present study are they have compared the effect of reading on IOP digital versus non-digital, where the same patient has acted as their control and the conditions were standardized, so they have eliminated the bias of other conditions which can affect the IOP. Now discussing the demerits, some of which I could notice are the instrument used for IOP check. They have selected eye care because they did not want to instill an anesthetic agent and they wanted a quick instrument, but here I quote a study which has given a repeatability coefficient for eye care as 2.67. Now most of the values in this study which has changed the, shown the change in IOP are within this value, so we do not know how much they are repeatable. Again, as we noticed, the baseline for digital text in POAG was not a true baseline, and so the ideal would have been to randomize the text reading with text and digital in different patients. The POAG patients were on different IOP lowering agents, and the effect of those IOP lowering agents on IOP, the time of installation, has not been taken into account. Also, the text selected for reading could have influenced emotion, and emotion has shown to change IOP. They could have used randomized collection of words to study to avoid this confounding. So overall the methods used were good, assignment was fair, assessment and results were also good. Interpretation I would not give a good because they have not given a clear explanation as to why they had an IOP spike with text reading. Not a single explanation, whereas the other studies have tried to explain why IOP drop was noticed with reading. Extrapolation is again fair because most of the glaucoma patients which we have are above 40, where the accommodation has already stopped dropping down. So Now, way forward to study in this arena would be study on changes in IOP with reading on e-readers, wherein e-readers have proposed less strain on the eyes as compared to smartphones, and also study on changes in IOP in real life setting, for example, IT professionals, which form a major population nowadays. Thank you.
Thank you, Vidya. That was an excellent study, and what is great about this study is it's extremely simple. It's very clear, very simple study. There are no really tough stats or anything, and it's published in the Journal of Glaucoma. So it's a learning. When you look at a study like this, it's been done very meticulously. But yes, like Vidya mentioned, there are a few lacunae as to they haven't interpreted or they haven't tried to find out as to why their IOP is kind of rising. They've just said that, as per the previous studies, that the reasons may be because of the extraocular muscle pressure pressing on the eye due to accommodation and convergence.
They have given it for smartphone, but for text
Digital
reading,
text,
they have not explained anything.
Right. And what is very interesting is, like Vidya mentioned, previous studies have shown that on reading text, the IOP decreases. So there have been a lot of old studies which say that the IOP decreases. And one of the reasons they say is that the accommodation convergence probably it increases, but the meiosis, which is induced when you read, that has an effect, along with what you mentioned about the ciliary process pulling the air and increasing the outflow. Yes?
Can you explain why Madhvagavad Gita and the Shamiri's text was, what will happen if you read different kind of books?
As I pointed out, it could have had an emotional influence on the intraocular pressure. Some collection of random words could have been better for a study.
But on the contrary also, there are thousands of evidence that definitely the smartphone are a lesser alternative to than your age. What is the utility of this? What is the utility of this paper?
That whether the IOP at all...
No, I mean that what is the base utility of the paper so that it is to be published in a journal of glaucoma. The subjects are actually decreasing.
The subjects are?
You have already squeezed the nimbu. Nothing is there in glaucoma.
No.
So this type of articles are being published in journal of glaucoma.
No. So
it's I object to it.
No, the reason what they've done is there have been previous... I'll tell you.
But just last a point of take. What is the effect of Trendelenburg position on the axial length and elevated intraocular pressure? If you make a patient in Trendelenburg position, does the axial length is going to change and the intraocular pressure?
Whether the IOP is going to change? Yeah, the IOP definitely, now we are kind of suggesting for MIGs, maybe the head end should be down, So there are a lot of one of the reasons I'll mention Shobhikda here, could you just, one of the utilities of why they did this study. Because if you look at previous studies, they have also done studies where you wanted to see the effect of reading on intraocular pressure. But what they've done is, they viewed a target at, let's say the first study, a target at 25 centimeter, and they put lenses to induce reading. That means they put either a minus 3D lens or a minus 6D lens. So it's a pseudo way. So all these studies which are mentioned, view a single row of 6 with a minus 4D lens or a minus 1.5D lens. So there have been a number of studies, and all these studies, they've shown an IOP drop. So if you see, the younger and the older age groups, the mean maximum IOP reduction. So there is this kind of ambiguity as to whether the IOP really decreases on reading or whether it increases. So there are studies which say it decreases, there are studies which say it increases. So you need more studies like this to kind of give a conclusion to this. Yes, it is, because this is another study which they have again kind of quoted in their study, where you can see here what they did was they studied it in daylight and low light. So they did the same study, but they studied it in daylight and low light. So what they found was, in daylight conditions, the IOP spike was not that high on smartphone work, whereas in low light conditions. So not only does this study prove that smartphone reading increases IOP, it says it increases IOP in low light conditions. So this is a very wonderful graph. Here you can see the actual rise in IOP. Here if you bring the baseline to 0, suppose you kind of convert it to 0, you'll see a spike of up to 6 to 7 mm for some of the patients. So there is quite a dramatic rise in IOP on smartphone reading. So these studies are really essential. Like for example, this is another study where what they found was if the anterior chamber depth was less, if the visual field defect was more, if the age was more, the IOP spike is more. So all these studies have an utility because they give out different information. They are all trying in different ways to kind of find out.
In the process, you get more confused.
No.
That's the thing. You are practicing at a hospital where
Yeah.
glaucoma patients are coming. So what
They will ask, no?
So, yes, they do ask.
Yes.
Yeah. And why?
And then, no. You go to Dipanjan will allow you smartphone. Don't go to Arijit because he will not allow you to use smartphone.
No, but Shobik, that this is the AO. This is the AO week in review. So this topic has been discussed that there is this study from India. It has been published April 5th, 2024. So AO is also kind of interested in this study. Like we are a humble journal club, we are discussing it, but AO is also discussing it. Sure.
This is probably little related to this, but this is just an observation from my part. So I am seeing maybe glaucoma patients for 20 years now, and the routine used to be almost in Arvind and also in Priyanka Birla and also in Disha now where I am practicing. That the patient comes first, he goes for when the patient is given an appointment for an automated perimetry. That day, the patient comes first, it gets an NCT done, he doesn't go for AT, then he get an automated perimetry done, and after automated perimetry, he comes for a doctor consultation and we see the intraocular pressure. That time the intraocular pressure is always high, and it not corroborates with whatever other day we see the patient when he is not doing automated perimetry. So probably a rapid eye movement or whatever you are seeing, maybe it relates to the same thing. So that happens, and I want to know anybody has observed like this or Dr. Moni has observed like this or not.
No, first let's answer Dipanjan's question. Mani sir, please.
So the automated perimetry is a stressful procedure. So obviously there are, squeezing of the eye and of course the stress involved, other factors, cortisol production, all those things are involved. So definitely glaucoma patients are going to react more to that. So that is definitely, we do see there is a little bit of increase. So we always do AT before doing any perimetry procedure for patients. Second thing about this study, just a couple of comments. Of course, they have done meticulously everything, but then I think there are two things which they have to consider. One is the position when they are taking the ICT. When they are reading, they have taken it. So the patient's head position is slightly lower. So when they are doing the ICT hit, it may be slightly in the periphery. It might still say correctly, but the corneal thickness may have a bigger role in the rise in intraocular pressure. So that one they have to consider. Second thing is obviously, whether the refractive correction for near vision has been done properly before or not, it's not clearly mentioned, especially in the open angle glaucoma patients who are slightly older. Obviously, there may be some squeezing effect, when they are reading, if the correction is not proper. So those two things, I'm not sure whether they have taken into account. That may have to be taken into account. And I think this is one study, and we need to do much more to really conclude and tell our patients. But generally, what we need to tell probably is, I always tell all my glaucoma patients, anything you are indulging in, do in moderation. So same thing, it applies for this also, I think.
So just one doubt, like they have measured multiple times, like 10 minutes, 20 minutes, then after smartphone 10 minutes, 20 minutes, so
Correct.
like more than 6-7 readings.
Right.
ICT is for 5 readings actually. So they have, whether they have changed the tip or not, that's a thing. So the later readings, that may be doubtful. That's
Correct.
one thing. And second thing is for the POAG patients, for printed text, the baseline IOP to the final IOP, the rise may not be significant, but eyes is more than the smartphone baseline and the end IOP. So,
Got it, got it. So that's an interesting point. So I'll just end by kind of stating what the previous study which I showed and which this study has quoted, that why does the intraocular pressure rise? Because A, there is sustained extraocular muscle contraction. B, there is accommodative convergence. C, there is neck flexion posture. D, there is dry eye. And E, there is elevated psychophysiological stress with smartphone. So there is another study which showed, as to somebody was asking why they gave the Bhagavad Gita, if you see a movie on the smartphone and then you measure the IOP is going to be even higher. So that is another reason. And this dry eye, what they mentioned is, because of dry eye, some of the nerve endings are stimulated. That stimulates the trigeminal nerve, that increases IOP. So dry eye can also cause a raise in IOP. So these are probably the mechanisms, so be aware. So I would move on to the next speaker. So I'll move on to the next speaker, Dr. Shurojit. Shurojit completed his MBBS from Bardhaman Medical College in 2007. He did his post-graduation training in ophthalmology from RIO, Kolkata and SN Chennai. He did his long-term fellowship in clinical glaucoma at SN Chennai and was awarded the FICO in glaucoma in 2018. He was inducted as a fellow in the American College of Surgeons, FACS, and he achieved the MNAMS degree in 2022. He has served as a consultant in the Department of Glaucoma and Cataract Services at SN Kolkata from 2016 to 2022, and he is currently practicing as a consultant in the Department of Glaucoma and Cataract Eye Services at Netraland Super Speciality Hospital in Kolkata. Now, Shurojit has a very complex topic. Just key points as to the lessons from the Glaucoma Foundation think tank. So this was a meeting which was conducted in 2023, and they summed up the results of that particular meeting. So a patient-centric approach to glaucoma care, what were their findings? So over to you, Shurojit.
Thank you, Arijita. And I am going to present the most interesting topic of this evening. So this is the topic I am presenting. This is the article which got published last year. This year. It is the lessons from the Glaucoma Foundation think tank 2023, a patient-centric approach to glaucoma. So what I could, information I could gather from the website, the Glaucoma Foundation think tank, this is it is actually a unique opportunity for scientists to apply the research and progress in other diseases and systems to challenges of glaucoma. This interdisciplinary meeting fosters creative thought and collaboration among the world's leading glaucoma experts, neuroscientists, geneticists, biologists, immunologists, and other specialties. This meeting is held annually. These are the author of this review. This one was the 28th annual Glaucoma Foundation think tank meeting, and it was held in New York in 2023. The aim of the meeting was to present the latest findings in glaucoma research and to foster the development of novel strategies to prevent and stabilize vision loss from the disease. The topics of discussion was the big data, genetics, modifiable lifestyle risk factors, female sex hormones, neuroprotection. The first one is the big data. So as we all know that databases with large sample size are typically more representative of a population and reduce the margin of error in estimating the relationship between an exposure of interest and the glaucoma. In this study, they have discussed about the large 4 repositories. The first one is the Intelligent Research in Site Registry, which has approximately 78.6 million participants. The second one was the National Institute of Health. It has almost 6,50,000 participants. The source, that is the Site Outcome Research Collaborative, and it has almost 4 million participants. And the United Kingdom Biobank, which is mostly the information we gather from for glaucoma, that is approx around 5 lakh participants are there. So there are some challenges are unique for this field of data science. If we apply the artificial intelligence and machine learning and mathematical modeling, they are becoming effective tools widely applied to this data now, and for understanding the risk factors such as the IOP, BP in glaucoma and improve the disease management. But we should also keep this in mind that given the concern of dissemination of false information linked to the latest AI developments such as ChatGPT, and there is a crucial need to ensure trust in data collection. Data standardization was also stressed as an important requirement for clinical interoperability and data extraction and sharing. Specifically, for glaucoma, the speakers underlined the critical need for universal standards and internationally recognized codes to create harmonized data worldwide and allow a standardized representation of disease and related data elements. Next part was the genetics. We know that primary open-angle glaucoma is firmly established as a highly heritable, polygenic, common complex condition. Dr. Stuart McGregor covered this genetics part and the genetics discovered in the field of glaucoma with important insights on their current and future applications, such as new drug target discovery, risk and outcome prediction, and the identification of modifiable risk factors in subjects at higher genetic risk for glaucoma. In 2014, data from a genome-wide association studies, meta-analysis conducted over 35,000 multi-ethnic subjects of 18 population cohorts from International Glaucoma Genetic Consortium, they identified 7 loci associated to IOP and glaucoma. A rapid increase in loci discovery then followed thanks to the new data available from UK Biobank that allowed the data from large cohort of the European Prospective Investigation into Cancer and Nutrition and IGGC, the identification of 112 IOP unique to this glaucoma, and it was recognized. And the understanding of glaucoma genetics was advanced further thanks to the advent of machine learning and artificial intelligence application. The latest GWS results combining across ancestries and using both IOP and AI-derived VCDRs in a multi-trait model, yielding an unprecedentedly large effective sample size, increasing the genome-wide number, the significant POAG loci, to 312. So new biological pathways for glaucoma were correspondingly identified, including developmental process loci, suggesting that the anatomic determinants of the aqueous humor and IOP in adulthood were predestined in the genetic code at birth, and lymphangiogenosis loci pointing to the Stam's canal and collective channels as crucial anatomic structures for the pathogenesis of glaucoma, and challenging the dogma of primary open-angle glaucoma as a juxtacanaliculaar trabecular meshwork disease. So the genetics variant of IOP identified in the UK Biobank were able to accurately predict glaucoma risk in the neighborhood study subject, thus confirming the importance of IOP in the pathophysiology not only of high tension glaucoma but also of normal tension glaucoma. So why genetic discovery is important? The identification of specific disease risk genes is particularly important for the discovery and development of new drug targets. When a drug target is supported by genetic evidence, the probability of its clinical approval is more than double, with enormous economic savings in the drug development pipeline. The concept of computing a polygenic risk factor for glaucoma aims to obtain a prediction of an individualized genetic risk by summing up the effect overall of all known at-risk variants, and it is based on the calculation of the effects combining over many loci. Polygenic risk score is not a diagnostic test for the disease. It represents a risk stratifying score able to identify subjects at higher risk of POAG and associated with clinical outcomes with a high potential in terms of clinical applicability. Genetic discoveries are also essential for the identification of links between POAG and modifiable risk factors in subjects at higher genetic risk for the disease. So coming to this last point, that is the lifestyle or modifiable risk factors for glaucoma. The environmental factors can either modify the genetic risk of disease or independent of genetic makeup influence the risk of disease directly. With advent of accessible and affordable genetic testing, early identification of subject at high risk for glaucoma will be possible. Thus, the critical need to identify behavioral risk factors that could allow patients to actively take responsibility for their disease risk reduction. Relationship between caffeine, alcohol, pollution, serum lipids, sleep apnea, sleep pattern, and POAG was discussed in this meeting. So first I'm coming to this caffeine part. It was noted that caffeine directly doesn't cause any IOP spike if it is taken in the regular whatever we take. But whoever is taking it in higher amount, whether it is causing any problem or not, that was evaluated. it was seen that who doesn't have a higher risk of glaucoma, who are not genetically predisposed for glaucoma, they don't have much problem. But if someone is having high PRS, that is higher risk of glaucoma, there is a almost 3.9-fold increased risk of having glaucoma if they are having high amount of caffeine every day. The same there is for alcohol also. Those who have high PRS, there is a possibility of glaucoma in them, but for others, the risk is not that much significant. For pollution, it was noted that a higher level of smart particulate pollution had a higher prevalence of glaucoma. There was no association was found between the PM 2.5 concentration and intraocular pressure. For serum lipids, the relationship between serum lipids and POAG is very much controversial. In a large cross-sectional study with data derived from UK Biobank, a consistent positive association was found between the various serum lipids, high-density lipoproteins and low-density lipoprotein cholesterols and IOP. Both HDL and LDL were positively associated with IOP, which is something in reverse to what we see in cardiology. The sleep apnea and sleep behavior is study on almost 4 lakhs participants from the UK Biobank. Snoring, daytime sleepiness, insomnia, short or long sleep duration were associated with the increased risk of glaucoma compared to healthy sleep pattern. Come to a very interesting part, this is the female sex hormone. There was no clear association was found with age of at menarche, parity, years of reproductive duration and or oral contraceptive use. Evidence shows that younger age of menopause as a potentially significant risk factor for POAG. Women's Health Initiative site exam, which had 2 study arms. There in one arm, one trial, women with prior hysterectomy were randomized into treatment with estrogen versus placebo, and in another trial, the women without hysterectomy were randomized to receive estrogen plus progestin or placebo. In the final analysis on the 8,102 women, no PMH use benefit was found in terms of incident of POAG risk overall. African American women treated with estrogen showed a risk reduced by half compared to the placebo group. As expressed by the think tank expert, it is still unclear if PMH use should be recommended by ophthalmologists in women at risk for POAG, since factors like time, dosage, duration of use, route of administration, and timing of initiation may affect the benefit-risk ratio. The neuroprotection. The neuroprotection in the field of glaucoma encompasses the treatments independent from IOP, able to prevent or delay glaucomatous neurodegeneration and to enhance the function and survival of the RGCs and their action. This is multifactorial other than the IOP. If you consider the environmental factors are there are metabolic stresses, the genetic contributions are there, neurovascular coupling, and also the neuroinflammation. So the challenges, there are various challenges which are unique to conduct these neuroprotection trials. The selection of target patient is very complex, as more strict criteria often leads to smaller sample sizes with less power to detect moderate treatment effects. The possibility of selecting patients who are rapidly progressing under standard therapy or who have various risk factors for progression has a disadvantage of more difficult recruitment. The visual field progression is considered as the endpoint of the study, which has reduced sensitivity in the early stages of the disease and high variability in the late stages, and multi-year long costly trials are needed to detect significant visual field changes. So the solutions could be selecting a new functional endpoint for the studies like rate of progression or time to progress. The structural endpoints of the assessment of optic disc, retinal nerve fiber layer or macula can be considered, but you should keep in mind that no structural outcomes have yet been approved for glaucoma trials by regulatory agencies. Artificial intelligence may facilitate patient selection and recruitment, identify suitable candidates trial based on the analysis of complex information from the electronic health record. AI may also help with data collection, analysis, and visualization. There also in this program, some patients were there who also given chance to express their personal experience, and they are told that easy to use portable IOP measuring instrument for home IOP checkup is a need for them, and also they are waiting for the newer medicine to get approval like neuroprotective agents. And they have critically mentioned about that the disease it has a psychological burden also. So definitely the psychological support for the patient is very much important. So to conclude, the genetics are important in defining the risk of glaucoma. Lifestyle modification can reduce the risk of glaucoma in high-risk subjects. Female sex hormones may play in disease pathogenesis for women. Neuroprotective drugs have a potential role in glaucoma, and their use in clinical practice is possible but may still require further study before its implementation. AI could be used as an important tool to extract critical information from the robust data, and it may be used for research and development for neuroprotective agents. Thank you.
Thank you, Shurajit. We really put you in a tough spot because it's a very, very dry topic. I know everybody's fallen asleep by now. Why we kind of chose this particular topic for this journal club is, I'll just take 2 minutes to sum it up and then we'll hand it over to Mani sir. So why we chose this topic is because now things have got very interesting when it comes to things like these, the genomic studies and the artificial intelligence. So I remember at one of the Disha consultant meets, Dr. Boschak had talked about big data. So this was in 2018 or 19. Now why are people talking about big data? The reason they are talking about big data is the UK Biobank has around 110,000 subjects. So this particular biobank, when you look at all the results, you come up with this startling statistic that systolic BP has the strongest association with IOP amongst all the other systemic features, whether diabetes is. So you have, this data is already there. You don't have to do a study. You just have to do something called data integration, data mining, data analytics, and data passport. So all these things are going to be very important. I mean, there are these banks. The UK Biobank is there, the NIH has a bank, and you can have access to that biobank. If you want to do a particular study, you can get access to that, but you need a data passport for that. So you need to be aware through these studies as to where you can have access to data. And there are these data are called big data because it's huge. It's in lakhs and crores. So if you plan to do a study, and I want to do a study on 100, here's the data bank of 110,000 people, which may already have something. A. B, regarding genetics, because we already have a lot of confusion as to whether POAG and what are the genes, etc. So studies like these, which involve big data, they have clearly shown that POAG is a highly heritable, polygenic, common complex condition. So you need genetic studies to establish, because maybe in the future, gene therapy will be one of the armamentarium in treatment. Now, how do you do this GWAS, the genome-wide association study? Now you go to AIOS, you go to these forums and you listen to GWAS and you don't even know what GWAS is, which I also didn't know, and it's very dry. But it's very interesting. You take patients, you take the patient's DNA, you select a group of non-patients and you take the non-patient DNA, and then you compare the differences to discover what are the areas which are associated with the disease. So the single nucleotide peptides which are associated with the disease. So once you compare the huge database of patients versus normal healthy volunteers, some things will stand out. So you know these are the areas which are causing the disease. So that is basically what GWAS is. So you will know exactly what are the genes which are responsible. So this is again very, very important. For example, I'll just give you an example. All this is from this particular study. So this GWAS meta-analysis, they initially discovered 7 loci. 4 of them were new between IOP and glaucoma. And then the EPIC, Norfolk and IGCC, these are again 2 data banks. Because they combined the data banks, they found 112 loci with 68 new locations. So, you know, if you have big data, you can come up with a large number of newer genes, newer studies, newer information. So, what they again found out was that the anatomical determinants of aqueous humor and IOP in adulthood, they were predestined in genetic code at birth. So, you know, some people, they were normal, and then suddenly they turn towards glaucoma, or the glaucoma was well controlled, and then suddenly the glaucoma increases. So maybe it is predestined, and it's there in the genetic code. And in fact, from these studies, they found some lymphangiogenesis loci, which Surajit talked about. So these are located in the Schlemm canal and collector channels. So which prove that POAG is not just a disease of the juxtacanalicular meshwork. So there are genetic loci in POAG patients which are there specific for the Schlemm canal and collector channels. So again, we come back to MIGS and maybe the blockage is there. Now, what could be one of the utilities of this? So this is not something which is there only in terms of academics. Already for cardiovascular factors and diabetes, polygenic risk score is a reality. For example, if your parents are diabetic, you can undergo a polygenic risk score evaluation, and you will get a value. Based on that, you will know whether you are at risk. Now, why is this important? Because Angelina Jolie, she underwent bilateral mastectomy along with salpingo-oophorectomy because she had a particular gene for cancer. So it's very important. People are taking it very, very seriously. So polygenic risk score will be like a report card. If your parents have glaucomatous, patients are going to come with that report card to your clinic, and then you will not have to rely on GCL, IPL. You will look at the polygenic risk score and decide what is the risk of this particular patient in terms of developing glaucoma. Also, these big data, they are challenging existing data. For example, the myocilin gene, the myocilin gene causes we've read that, but now what it's stating is it has only a modest contribution. So, because big data is not suggesting that, maybe individual studies were suggesting it, but big data is not suggesting that. Now, Surajit has already covered this, but just the take-home messages, the gene-caffeine interaction. So, there is a gene-caffeine interaction. So, what they found out is if you have caffeine in higher doses, your IOP is really not going to get affected if you are healthy. But if you are genetically predisposed, then, and if you're genetically predisposed to glaucoma and you take a lot of caffeine, then your IOP is going to rise. Because there's this gene-caffeine interaction or the IOP-PRS caffeine interaction. So it's very complex. Therefore, the answers are not simple. Whether caffeine intake is going to cause glaucoma, because there are a lot of other factors which are involved. For example, this particular study, you can see that, alcohol intake increases IOP, it decreases macular RNFL thickness, it decreases macular GCL IPL thickness, and it increases prevalence of glaucoma. Now, all this is within the allowed limit in the UK and the US. So there is a weekly allowable limit of alcohol intake. So all these are within the weekly allowable limit. So your IOP is going to rise even if you take it what is kind of standardized as normal. So these are very important data which has come out. For example, air pollution. So higher prevalence of glaucoma is found in regions where there is more pollution. This is from big data, according to POAG clusters and air pollution. And patients living in areas with higher air pollution have thinner ganglion cell IPL. So these are things to think about, because big data gives you a different perspective. You may do a study in one region in Dehradun and you may not find it, but you may do it in Mumbai and you may get a different result. Also lipids, like Surajit mentioned, it's very complex. But what is interesting is, maybe the lipid pathway is very different, because both HDL and LDL, they were positively associated with IOP, which means if your LDL is high, your IOP tends to be high. If your HDL is high, your IOP tends to be high. So it's very weird. So, and sleep apnea, again, no genetic causal association has been found between sleep apnea and glaucoma. Female sex hormone, again, very interesting. Younger age at menopause increases the risk, and use of PMH probably, specifically estrogen, probably reduces the risk. And last is AI is going to play a big role. So this study kind of talked about that deep learning model of AI, it detected RNFL segmentation errors as at least as well as highly qualified centers. So AI is now reading glaucoma print better than us. Also, deep learning models trained to detect glaucoma on raw CT scan outperform the summary parameters. That means the machine, the data that it gives, if you put the raw data to AI, it gives better results. So it's giving better results than what we see on print and we interpret. Also, deep learning algorithms, they are highly diagnostic accuracy for differentiating between eyes with and without glaucomatous visual field damage and predicting the severity of the damage. So if you give a deep learning algorithm to the OCT on-fast optic nerve image, so you just take the optic nerve image, the AI will predict what glaucometer's visual field damage and the severity of the damage that that particular optic disc will have. So in future, maybe visual fields will need not, I mean, we may do away with visual fields. We'll just take an optic nerve head image, ask AI to predict what will be the visual field image. And also AI is able to detect progressive OCT assessed RNFL thinning based on just fundus photograph. So you take a fundus photograph and it will give you a predictive model over the next few years what is going to be the RNFL thinning. So all this is a summary of this particular study. So the think tank has thought of a lot of things. So it's very, very interesting. It's the only thing is very, very boring also. So that's it. So thank you, Shurujit, for giving us this insight into this particular subject. So we'll now move on to the most anticipated talk of the evening. Yeah. So I'll just introduce Sir. Sir is because I kind of pestered Sir for this CV over this past week. So Sir is a senior glaucoma consultant and deputy director of glaucoma services and research at SN Chennai. Formerly a clinician scientist at Singapore Eye Research Institute and SNEC. He had completed his DO and DNB in India and PhD from National University of Singapore. He manages complicated cataract and glaucoma, including pediatric glaucoma. He is active academically and mentors postgraduates, optometrists, and PhD students. He has more than 300 international publications, with an H index of 52, 8 book chapters, 6 co-patents, 150 plus international lectures. He was involved in 4 major epidemiological surveys and several RCTs in India and Singapore. His current research focuses on imaging, diagnosis and management of angle closure in Asia, clinical trials and software algorithms of the anterior segment imaging, and he was awarded the Transition Award and prestigious Engineering Award for Medical Innovation by the NMRC Singapore. So what is the standout thing here is the H index of 52. So, I mean, even if I had not written anything and I just mentioned, Sir has an H index of 52, you should be, standing up and, because, yeah, it is like a PR score. So, the H index, what they say is, anything above 20 is great, anything above 40 is amazing. I mean, to apply for a Nobel Prize, you have to have a minimum H index of 40. So it's a bit difficult to calculate. I mean, like, you have all your published or indexed publications, and then the citations, you kind of cite them. So Sir has more than 300 international publications. So what a H index of 52 actually means is that more than 52 of his articles have been cited 52 times, at least 52 times. So to have an H index of 52, you need at least 300 publications. Yes, there are some people with H indexes of, I think, 200 or 250 Nobel laureates who are cited. But H index of 52 is just amazing. Means 52 articles of Sir's have been cited, each article more than 52 times. So I would love to hear from Sir. And before Sir comes on stage, we'll just facilitate.
Yeah. On behalf of all of us, I'll request Yasin Sir and Sumit Chaudhary Sir and Dr. Devashish Das Sir to please felicitate Sir. I'll request Yasin Sir first to give the Uttari on behalf of all of us. I'll request Sumit Sir to please give a small token from all of us. And I'll request our secretary, Dr. Devashish Das Sir, to give a memento on behalf of all of us. Yasin Sir, can we have a group photograph? Yasin Sir, please. Thank you, Bhaskar Sir. The stage is all yours, sir.
Thanks a lot for all the kindness. I know you're all hungry. There's an advantage of coming in the last. There will be less questions, I hope. I would like to congratulate the OSWB on this 25th Journal Club. I know it is not an easy job to come to this stage. It needs a lot of perspective, passion, and perseverance from the office bearers as well as the audience to come to this. So once again, I would like to congratulate. Thanks, Manish and Dr. Arjit, for inviting me and hosting me here. I was given this topic, glaucoma management lessons from the past decade. There is a lot of lessons and trepidations as well. You can see this in the timeline. There is so much of medications that have come in the last few years, and also a lot of procedures that have been there. I'm not going to talk about those, but I was asked to concentrate more on the clinical trials, and of which the light trials, the tags, and the angle closure trials, and the glaucoma intensive treatment study I would be concentrating on, because that have certain lessons for us to practice in day-to-day clinical practice itself. And of course the OHTS follow-up for 20 years and EMGT follow-up, just one-liner. Maybe 40% of patients progressed in the 20 years, and those with high risk progressed more. And that's what I would say in a nutshell, and there is some racial, ethnic specifications as well in that. Early manifest glaucoma trial, of course, showed that delaying the treatment to some extent in early glaucomas did not have much impact, but there was a small visual field loss penalty for those patients who were treated later. So apart from that, I won't touch much on those. Now the clinical trials per se, they provide evidence-based guidelines for clinical practice. Why are we bent on evidence basis? Because when we assume things from our experience, we may be wrong. Because what we are seeing is a very small group of patients. And based on that, if you are going to treat all our patients, we may be at fault. Because especially glaucoma is a diverse condition. As you saw in the think tank, you can see that there is an interaction of gene, there is environment, and of course there is a racial component as well. These are all what we are seeing in our eyes. And there is a lifestyle component, there is a hormonal component. So each individual patient has a complex environment in which he is there. And if we base our experience only to treat our patients, most often we may end up wrong. So that's why we need these evidence-based clinical trials. Apart from that, it also helps in cost assessment for public health initiatives and provide assessments of results of treatment for quality of life. Because do no harm is very important. If we end up going to treat our patients based on the efficacy alone and not give much heed to the safety, we may end up harming our patients in the long run as well. Especially in terms of when a patient with glaucoma is going to be with you for the next 20 years, probably he is going to outrun your own lifespan and may require a trabeculectomy. Keeping the patient on multiple medications or multiple surgeries initially may cost his vision in the end. So that's why we need these RCTs. An issue specific to medical treatment in India is cost, adherence and persistence, difficulty in obtaining the medications, which I see it more often. We write a certain medication and then the patient goes back and comes back to you with sometimes not using the medication or a different kind of medication. That is very common in our country. So one of the studies which I quote all the time is the light trial, the selective laser trabeculoplasty. I know there is a difficulty in access to the machine itself. I hope there is a more initiative in getting cost-effective machines within our country itself. I hope some of the companies will take up, and Apasami is taken over by Warburg recently, so hopefully they should be coming up with some of these cost-effective machines as well. And these light trials have been an observer-masked RCT, and treatment-naive PYAG or OHT patients have been included in this trial, and a comparison of SLT, selective laser trabeculoplasty, versus IOP-lowering medications have been used. Their primary outcome is on the quality of life for 3 years initially, and cost effectiveness were studied, and clinical effectiveness and safety were secondary outcomes. A lot of patients have been included, 356, 362 in each group. Final analysis was done for 329 in the SLT group and 323 in the medication group. And the technique used was 360 degrees of treatment, 100 non-overlapping spots, 25 per quadrant. Laser energy was 0.3 to 1.4 milliwatts or millijoules. Now this is very important because most often when we try to do the laser, we may under-treat. we need to stick to the initial protocol as well. And of course, the mean deviation between the groups were similar. What is to be noted is 74% of these SLT patients. You should remember that these patients have been washed out. Their diurnal IOP was taken. That is something which was not done in those mixed RCTs. They have not done the IOPs throughout the day. This particular study, they have done the IOPs throughout the day, and they have taken the mean. So 74% of SLT patients were drop-free at 36 months, at least 70% of them. This, if you are comparing it with the mixed outcomes, I will leave it to your own conclusions. So it is effective in a way. Now, of course, the QOL between the two groups were similar at 3 years. 6 years was different. SLT had better outcomes. And average cost was lower. Of course, in UK perspective, from our perspective, it may be different, but we need to see. And of course, at the 6 years follow-up, 524 of these 692 patients were included for follow-up for the extension trial, and 524 completed 6 years of follow-up. No significant difference in QOL parameters except glaucoma symptom scale scores were better in the SLT arm. And again, 70% remained drop-free in SLT arm. That is what we have to consider, of course. Of course, it is not like, a permanent solution or anything. We need to consider this as the mix procedure first before probably considering the other procedures. That's what I would leave you with the message here. Trabeculectomy was needed in 32 eyes in drops arm and versus 13 eyes in the SLT arm. Of course, more cataract surgeries were again needed in the drops arm. Repeat laser, when it was done among 25.9% patients, at 18 months, 67% of the 115 eyes remained medication free. So it is possible to repeat the procedure also. That's the kind of conclusion for each of these trials. 74% drop free at 3 years, 67% after repeat light after 1.5 years, and 70% at 6 years were drop free. And less progression was seen as well. This is something which we have to consider. And so what changed in our practice, at least at the SN, is that we keep offering SLT for OHT and early glaucoma patients. As you can see that I wouldn't consider MIGS in OHT but SLT in OHT patients, especially for treatment-naive patients, because it seems to be effective in patients who had slightly higher intraocular pressure to begin with. Sometimes some of the practices to wash out on medications and do the SLT also, but we don't do it for practical reasons. And repeat SLT is effective and we often use it. Of course, from the India perspective, angle closure is a common problem, and we often scratch our heads about asymptomatic narrow angles, what to do. Should we do a PI or not? Even though it is a simple procedure, it has its effects and it increases the cataract as well. So 2 RCTs, one of which I was fortunate to initiate and follow was the Analyst trial in Singapore and ZAP trial in China. Efficacy of LPI over 5 to 6 years were looked at. This is the methodology. They randomized one eye to LPI and no treatment in the fellow eye. And in the China study, there were around 900 patients. In Singapore, were 480 patients. That was the sample size which was calculated based on the progression rates in each of these places. The South Chinese were more in the Singapore group and North Chinese in the Analyst group. The ZAP group. Now, in both the groups, the hazard ratio of not doing LPI was 0.5. So basically, it was protective in 50% of patients. And if you see, actually, the progression was 4% in the LPI group and 7% in the non-LPI group. And that is something which is only 10% of this population were progressing and 90% were not progressing. That is something which we have to keep in mind. Majority only progressed to primary angle closure with some PAS. There is no visual field loss that much. There are very few patients who had glaucoma. So this is something which we have to keep in mind while we are offering PI for our patients. Risk factors were not identified in the Chinese trial but in the Singapore trial. So if you can see that narrower angles at baseline, higher baseline IOP, higher post-dilatation IOP. This is something which we can do it in our clinic very easily. Diabetic patients, age and male gender. These are all things which are risk factors for progression in the Singapore trial. Now, the number needed to treat, we know that LPA was protective in a small group of patients, but the number needed to treat was high. So I think we need to come up with the thing, and this is something which was there existent in the World Glaucoma Congress guidelines itself, and some of the other guidelines which may be more applicable to our environment is blotchy TM pigmentation, and of course family history of primary angle closure disease. These are things which we need to consider where PA can be done as well. Now this EAGLE study, I was part of this study, but then subsequently we withdrew from this for several reasons. Now cataract extraction in LPA, it is kind of becoming a craze. Of course, the mixed procedures have shown that cataract surgery, even in open angle glaucoma, shows a drop in intraocular pressure. And it was primarily looking at the QOL, quality of life of the patients, and the secondary outcome was the intraocular pressure. 204 patients in each group were included. One group underwent cataract extraction, the other group underwent LPI. And in this, the difference in the intraocular pressure was shown to be significant, but we need to consider the inclusion criteria and the other factors. And one more thing which we need to look at is the gonioscopic data was missing in 60% of these patients. So that is something which is really sad, because it was an angle closure study and we don't have the gonioscopic data. And of course, the complication rates in the clear lens extraction groups, they call it as clear lens extraction, but most of the patients who were included had some amount of cataract, and that is why the QOL improved, because the vision improved in those patients. And these were done with experienced cataract and glaucoma surgeons after excluding difficult cases. This is something which you have to keep in mind when this kind of patients are assigned to our juniors. Authors accept complications can be severe, and inexperienced surgeons could have increased rates. That is there in the paper actually. So this is something which we have to keep in mind. Surgical treatment for advanced glaucoma is something which we have to consider in our scenario in India. Very low target IOPs are needed, risk of wipeout is there, high prevalence of ocular surface disease, etc. So this particular study, primary trabeculectomy for advanced glaucoma as an RCT, is something which is tried to answer that. Similarly, both the groups, drops arm and the surgical arm, had similar visual field loss, which is the severe group. And visual field loss in the trabeculectomy group was slightly lower compared to the medication group. Not huge difference at 2 years. Again, this was no difference in primary QOL outcomes, and the tendency in the surgical arm for less progression and more cataract surgery requirement was there. That is something which we have to balance between the two. Of course, this is more in terms of advanced glaucomas, and in our patient perspective, this may carry some weightage. In this context, I would like to suggest something. More and more we are seeing that there is hesitancy in doing glaucoma surgery in patients who have split fixation, and we do see that patients coming at the later stages to us being on medications only. And this study which was done in our hospital, and Manish is also part of this study, and you can see that these are all the kind of patients with very high visual field loss, and at the end of the day, with both trab and the phacotrabs, we did not have any wipeout in these patients. So it is a rare phenomenon, and reversible causes of drop in vision were present at the end of the study. All the three maintained vision after appropriate surgical treatment. So I think we should be able to offer these patients the lease of vision by doing these surgeries, and not postpone the surgeries until they end up with the split fixations as well. So this is the take-home message here. Advise surgery when MMT fails, and avoid deferring surgery until loss of vision occurs or severe OST develops. Now this is the last study which I would like to put up here, glaucoma intensive treatment study. We do see that there is polypharmacy that happens. Of course, for several reasons we don't encourage that, but this study puts up a certain perspective here. Patients who are newly diagnosed POAG or pseudoexfoliation glaucoma, around 242 patients were randomized to multi-drug intensive treatment versus conventional stepwise treatment starting with monotherapy, which is the guideline basically. And in this, at 1 month, the multi-drug therapy group had a better control of intraocular pressure, and the percentage reduction of IOP is very high. Of course, whether it is really needed for this group of patients or not, whether the side effects, they had almost 55% patients with ocular surface problems compared to maybe in single digits in the monotherapy group. That is something which we have to consider. But at the end of the day, these patients also had lesser median rate of perimetric progression, but I don't know the repeatability, all those things were a matter of concern. So longer follow-up is really needed to see whether really this multi-drug therapy is there or not. So to conclude with the clinical trial summary here, I hope we had some take-home messages for our clinical practice from that. What I would prefer is keep up with the literature, especially on randomized control trials, follow the guidelines developed with this evidence, and we should practice with that evidence all the time. And remember that these evidence holds good only with the type of patients included in the trial and may not be the same with those excluded. So in other words, we should always look at the small letters in the trials. Thank you very much for your kind attention.
Thank you, sir. It was really a pleasure listening to you, and a lot of important and key points you highlighted from these major trials. If we have any questions for sir, anyone? Yeah, yes, sir.
Yeah, my question was to sir, that now with all this thing in our mind, so the moment you see a patient with very advanced field defect, say the remaining visual field is 20% and a high pressure glaucoma, so do you start a multi-drug therapy trial or you ask the patient to go for a trab or a monotherapy? What is your practice?
I think it is a good practice to start on monotherapy itself, because we all know that there is a regression to mean. But also we need to consider the decompensation at the trabecular meshwork level for a patient who is more severe. So in those patients, the IOP is going to rise after some time as well. So it is important for us to keep the patient on close follow-up, but at the same time, I would always prefer to start with the monotherapy, especially the prostaglandin analogs, which will reduce the intraocular pressure by at least 30% in the beginning itself. Because one thing is, the burden of more number of medications. And the second thing is to keep the medication numbers lower so that these patients are going to require a trabeculectomy. And we don't want to compromise the conjunctiva to the maximum extent. So it is a kind of a balance, definitely. And I wouldn't say that, it is wrong to start, a combination medication, fixed combination medication, because it is recommended in some of the guidelines. In fact, some of the Canadian glaucoma guidelines actually prefer fixed combination in patients who have visual field loss more than 12 decibels. So it is a kind of a balance, I would say. And also we have to keep in mind the cost to the patient in terms of thing. And more importantly, if the patient is going to require a surgery in the near future, I think we would like to keep the number of medications at a lower thing itself. What I will do is I will start, and then in a couple of days I see the patient, and maybe a month later again to see if the IOP is going up, if that is a possibility. But most of our patients come from outstations and we end up putting multiple medications.
So that slide on the PI hazard.
Is this the one?
Yeah. So 0.53 is what?
So it's a hazard ratio compared to the LPI versus control. So there is a 50% protection for the LPI group in terms of progression at 5 to 6 years.
Okay. And what SLT machine do you all use, sir?
SLT? We actually use the luminous. But that is the only thing that time it was available at that particular cost. So I think there is, of course, the Zeiss thing is available, but it is very costly now. But the problem with that is, we are not able to see the bubbles. So we don't know the end point or the point at which we can titer back. So that, Zeiss. We are using luminous as of now, and that is good enough. Actually, we are getting decent 360 degrees. From the beginning, we have been doing 360 degrees.
That's what I wanted to ask, like 360 degree, and when you need a repeat, you again repeat 360 degree.
Yes, we can repeat 360 degrees, but I usually wait till 2 to 3 months, because that is when the actual effect of the SLT comes. And by the end of 3 months, we will know if the drop in pressure is 20% or more, then it is effective. Beyond that, we cannot expect from a SLT. But if it is like 15 to 20%, then we can actually repeat again. But if it is less than 15%, then we have to consider it as a non-responder. So
Okay.
you may want to consider other type of treatment.
So the other thing is this, that, like you've been doing SLT for a long time. I have a little bit of experience, but what I want to know is that, that repetition, initially when a SLT is working, what in your experience is the median range when it starts, the effect starts regressing and you do a secondary 360-degree SLT? Like, would it be 2 years or 3 years or more than that?
I think these patients might require some other treatment by the end of 2 years, but what I have seen is, up to 1 year I have repeated, and then I have seen that, we are able to keep postponing the procedures or number of medications. So
But that's good enough, actually.
sorry?
The surface, ocular surface will be very good.
Yes, so that is the reason. We are talking about 70% of these patients who are, initially treatment naive patients. That is one important thing. Actually, I have started doing patients who are coming in, I have started offering them that can we do an SLT with medication. Unfortunately, I'm not able to take them off the medications because, we are always having that problem that the patient may not come for follow-up in our perspective. So if they are coming for regular follow-up, then even do an SLT and follow-up is good. But it is better to keep on one medication at least.
Experience versus netasodil and ripasudil?
I'm sorry, I didn't get the question.
Your clinic.
Netasodil versus ripasudil. Netasodil versus ripasudil.
I usually use netasodil because it is once a day, so that is the only difference. But I think with ripasudil, I do see more hyperemia as well. So that is the reason why I use netasodil most of the time. It is also very convenient in terms of once a day dosing. But if we have a corneal issue, we may tend to use ripasudil because it has endothelial protective. With netasodil, we do see more of the honeycomb keratopathy as well. So we don't use that.
Do we have any other questions for sir?
So regarding the drop in IOP, which would you prefer? Like which you have found, the netasodil or ripasudil, which has caused greater drop in IOP?
I have not seen much difference between the two, but the drop also is actually very patient dependent. That's what I have seen. And from the initial studies, if you see, only 20 to 30% of patients have a drop of almost 20%. Rest of them only have 15% or less only. So I use it only as a third line medication, not even as a second line medication, because we do have other medications which are second line. Okay. But in terms of convenience, I think netasodil is better, and Ripatec I have used only in specific cases. Yes.
So, shall we be justified if we do a LPI in a patient who is symptomless, otherwise symptomless with narrow angles, but he may not be turning up, he has a family history of glaucoma, he's diabetic and all these situations?
Sorry, I'm not getting the question. Can you?
Sir,
I'm not sure if
like,
that's echo.
Symptomless,
Yeah.
symptomless patient, a patient of PACS, symptomless, but because of logistical reasons will not be able to follow up. So are we justified in doing a PS?
Yes, that is one of the reasons why the medical access or follow-up is not there, then we end up doing it. Definitely, that is one reason. Of course, there is also this consideration of early cataract extraction is also something which is needed in such patients as well.
Thank you so much, sir. I think this is probably all the time we had today. But we'll request you to be on stage and please give small memento to all our speakers and panelists. We'll start with Dr. Debashi Chakravarti, please, Dr. Vidya, and Dr. Surajit Sen. Please come to the stage. Ravi. We also have a very special cake for this 25th edition. I'd also request our panelists, Dr. Nilay Majumdar, Dr. Alokesh Da, Dr. Dipan. Special 25th edition mementos.
It's customized.
Arjit is both speaker and moderator. Dr. Shovik Banerjee. Surajit. Sumit sir. Suchanda Di. Dr. Thakur and Maitri madam. Thakur sir.
And now our two moderators who have made the session extremely interesting and interactive. Dr. Arijit Mitra.
Arijit was speaker, moderator. Speaker cum moderator.
And Dr. Manish Singh. Last but not the least. Thank you.
I will request the speakers and panelists to please come to the stage for a group photograph and also for the cake cutting.
We can ask all participants to, everybody in the hall, we can get together for a group photo, I think.
We are excited by the discussion by Arijit. So I am planning my new study, the relationship between glaucoma and filaria.